Okay, thank you. There are a lot of really surgeries done for facial palsy, but I'm gonna focus on ophthalmic one because there is a lot for the face to be done because of sake of time. As you know, the facial nerve is really important, not just for function of the eye, but also for cosmesis, and also one of the things that maybe we don't pay attention enough for the psychology of the patient. So we need to tackle all these in the same time when we manage these patients in our clinic. The facial nerve is a complex nerve, and it has a long way to travel, and it goes from the brainstem to reach the eye. It has many stations to pass through, and at any given station, there are a lot of pathology can affect the facial nerve, and can be summarized the main causes for facial nerve palsy. And as you know, we see in our clinic mainly the lower motor neuron lesion. We don't see the upper motor neuron lesion facial palsy. The most common being the Bell's palsy, followed by infectious, inflammatory, etc. What the ophthalmic manifestation in adult with facial palsy? Typically, they present with eyebrow ptosis, lagophthalmos, ectropion, entropion mainly in children that we see, upper eyelid retraction, and also lower lid retraction, exposure keratopathy, and epiphora. This is a typical patient presenting with the facial palsy affecting the right side, and you can see the lagophthalmos. Brow ptosis is not that obvious because he has a senile brow ptosis on both sides. And when you get these patients, we need to take a detailed history along with the thorough examination for the eye and also for the face to look for the possible causes for facial nerve palsy. Then after that, may need imaging and lab investigation depending on what possible the etiology the patient is having based on your history and clinical examination. Typically, the question, do you need to image or not? If it's a slow onset symptoms of facial palsy, that means there's something compressive slowly, so I recommend imaging these patients. And if the patient is not improving over a few months of onset, I recommend imaging. And also patients with recurrent facial palsy, they deserve to be imaged. So how you manage these patients? Usually if patient with facial nerve palsy need to be managed with multi-specialty involving ENT, neurologist, and depend on the patient's symptoms. Even you need to involve psychologists whenever it's needed. And the ophthalmic manifestation or ophthalmic management depends on if the recovery expected or not expected, based on the cause for the facial palsy. So if you expect a recovery for these patients, you use a temporizing measure. That can be topical lubrication, batching of the eye. Sometimes you do temporal tarsorrhaphy, and also you can use botulinum toxin for the temporary closure of the eye till the patient recovers. And this is just to show you the Botox injection as a temporizing measure. You can do it through the lid crease incision, or through the lid crease approach, or you can do it from the conjunctival approach. This is our patient who presented with acute facial palsy and was ischemic in nature because he is diabetic and hypertensive, and for recovery, so we don't need to do anything for him. So what about the patient who really didn't improve? We need to go and do permanent measure to help these patients. And there are different options, and this depends on the patient clinical finding. So we need to correct lagophthalmos, lower eyelid malposition, brow ptosis, and blepharoplasty, lacrimal surgery, and orbital surgery, depending on the clinical presentation. So if a patient has a problem with the blinking and exposure keratopathy, you can do tarsorrhaphy. Tarsorrhaphy and Botox injection, this is a static measurement for helping the patient, but it's not addressing the blinking. So if you want to help the blinking and improve the lubrication of the ocular surface, you need to do either gold weight or botulinum chain implant, or you do the lid spring implant. This is just a picture for the gold weight. This is a patient before placement of platinum chain. You can see the eye is not closing well. And this is her picture after the implantation of the platinum chain. You can see the blinking improving. And this is the main aim of the placing the weight in the upper eyelid. Permanent tarsorrhaphy, it's something that I don't like to do unless I have to do. And because I'd like to use other options before going to permanent tarsorrhaphy, because most of the patients, they don't like having their eyes closed either medially or laterally. So what other things you can do to avoid permanent tarsorrhaphy? You can do either lower eyelid tightening with elevation of the median and lateral canthopexy or canthoplasty. It depends on the laxity. You can resist the upper eyelid or lower eyelid. And also you can do a spacer for lifting the lower eyelid, mid-facelet elevation. And also you can combine that with the weight placement in the upper eyelid. This is lateral tarsorrhaphy. Most of the patients really don't like this, so I tend more to do more of paracentral. I find patients to a little bit more accepting this appearance than the lateral tarsorrhaphy appearance. A patient with a very lax mid-face and lower eyelid, they need to have fixing of or tightening the lower eyelid, and maybe you need to do lateral tarsal strip along with mid-face lift. Interesting, we look at our patient who presented with facial palsy in pediatric age group. The interesting thing I want to pay attention at the last part of the slide is the entropion is more common in children compared to ectropion, and this is not opposite to what we see in adult. This is a patient with the entropion secondary to facial nerve palsy happened because of the complication for otitis media. This is after surgery. Lower eyelid retraction is also one of the common things we see, especially among childhood onset facial palsy. And these patients, it's good to use spacer to lift the upper eyelid, to lift the lower eyelid. And there are multiple options available. Either you can use sclera, or you can use hard palate, or also you can use synthetic material like porous implant, or in this patient we use a BDS sheet that I've been using for a while that helped lifting the upper eyelid. Lower eyelid, sorry, and this is a picture after the surgery. Sometimes we need to combine more than one procedure for the same setting and to help the patient recover well. This patient had a problem with the lag of thalamus, as you can see in the left side, and this patient, we did for him gold weight for the upper eyelid and suture lid sling for the lower eyelid to tighten the lower eyelid. Brow ptosis is another issue that these patients presenting to us to help them, and the type of procedure to help these patients would depend, in my opinion, in the heaviness of the brow and also the severity of the brow ptosis. If the patient is having not the medium heaviness of the brow along with mild to moderate brow ptosis, I will do indirect way of lifting the brow, and typically I use a pretracheal incision to help these patients. And this is her picture after surgery. If the patient is having a heavy brow and moderate to severe brow ptosis, I use the direct browplasty, because they need really a strong lift to have both brows symmetrical. Regarding the tearing, you can use either botulinum toxin to decrease the reflex tearing, along with paralytic ectropion correction if it's present. And also, if there is apparent innervation, maybe Botox is a good option. You can also you go for more invasive lacrimal procedure, drainage, to improve the patient's symptoms. This is, I'm gonna finish with this one. Sometimes maybe orbital decompression can help these patients with facial palsy, especially in my opinion, prominent eyes with mild lag of thalamus, like this patient. On the left side, he has some lag of thalamus and prominent eyes. So doing orbital decompression may help these patients to improve both cosmetically and functionally. Interesting that we see frequent patients come to our clinic with hemifacial spasm following facial palsy. Actually, 50% of our patients are secondary to facial palsy. So in these patients, botulinum toxin will help. And also, if it's not improving, you can do orbicularis myectomy to help these patients. And by this, I conclude, and thank you so much.